Thank you, Sarah, and thank you, Stephanie. She put a lot of this together, as did Debbie Ramsberg's staff for SIR, so we owe a lot to them. Let me just ask, how many of you know ICD-10, have gotten started at your own institution, and have been involved in this? Yes? No. Uh-oh. All right, so my job is to kind of give you some background on ICD-9, ICD-10, the conversion, and then Stephanie's going to go into actual clinical detail a little bit more. So ICD-10, there are two parts to it. ICD-10 CM, which is the International Classification of Diseases Clinical Modification 10th version, and this is basically the set of diagnostic codes, diagnosis codes, and it's the set of codes used by both physicians and hospitals to report diagnoses. The ICD-10 PCS is the procedure coding system, and its procedural codes. These are used by hospitals and facilities. Physicians do not use ICD-10 PCS codes even if you're performing a procedure in a facility or hospital. You will still report by by CPT. But the facilities, the hospital, will report the procedures by ICD-10 PCS. So basically what you need to know is the ICD-10 CM. ICD-9 is outdated. I didn't know this. I didn't know the history of it, but it was developed by World Health Organization in 1975. That's how old it is. It reached maximum capacity long ago, and it is no longer able to expand to keep up with current practice, especially in certain sections. So it's been locked in for a while. By converting, there will be a benefit globally because many other countries transitioned to ICD-10 long ago. It was actually developed in 1994. That's how long we've delayed it coming here. But once we convert, we will then be able to compile and compare data globally. And that, you will find, is going to be crucial to our future. There are other benefits of ICD-10. The clinical data will be more precise, which will lead to better data for research and analysis. Hopefully we'll get to outcomes of therapies more precisely, which will be good for all of us. It will improve quality reporting because there will be greater detail. It'll be improved accuracy for assessment of medical necessity, which should direct coverage and payment policy. Payments should be more refined because you'll be able to drill down to a higher specificity on the severity of disease, for instance. And probably not initially, but eventually it should lead to more timely payments. It's also intended to help enhance detection of fraud and abuse, and I don't know if you guys pay much attention to this, but we spend billions of dollars fraudulently. People take home that money, and instead of going to patient care and in your pocket when you're providing care, it's going to fraud and abuse. So anything we can do to decrease fraud and abuse is in all of our favors. So a little bit of comparison for the ICD-9, the diagnosis codes we currently use, 3 to 5 characters in length. The new ICD-10 will be 3 to 7 characters, and it will be alphanumeric instead of just numeric. There's about 13,000 codes in the ICD-9 book. There's about 68,000 codes in ICD-10. ICD-10 is flexible. We can add new codes. It's still got lots of expandability. It's very specific. It has laterality. You have to specify right and left versus lack of laterality in ICD-9. It gives us detailed descriptions of anatomy versus generic terms of anatomy in ICD-9. And there are more chapters, 21 chapters versus 17. So expanded, I'm sorry, I'm blocking on the word. We'll just go on. I forgot that word. Sorry, it's not so good getting old. So ICD-10 PCS, we won't go into that too much detail. You really don't have to know PCS codes. They're more hospital facility. So this started, the process to convert to ICD-10 started in 2009 when the Department of Health and Human Services said that we would convert in 2013. In 2012, it was announced that it would be delayed because the systems weren't ready. and it was to be delayed till 2014. In 2014, Congress again delayed it until 2015, and I guess there's talk now that it may be delayed again, although my sense is that it's going to go forward. There's been so much money invested in this by so many practices that if we don't go forward at some point, that's just tons of wasted time, effort, and money. You need to know about this. You need to act on this. If you don't act on this, it could be severely detrimental to your practice financially. When the conversion occurs, that will be overnight. It's scheduled to happen on October 1st, 2015. And after that point, after that second, when it turns to October 1, you may no longer file claims with ICD-10. It is a drop-dead date, and you don't get any grace period. The software must be installed and has to be compatible with all users. Just because you finally get it in there and are using it doesn't mean it's going to talk to the other systems. It must meet HIPAA standards. And ultimately, you, the physician, is the one who is responsible. If you can't bill on October 1st, you won't get paid. So, no grace period. Anything that you do to a patient and bill prior to midnight on 9/30/2015, it will be ICD-9. At 1 second past, it will be ICD-10. If the patient's in the hospital and the billing occurs after midnight, even what happened to the patient before midnight will be billed with ICD-10. So this is a real potential for disaster in so many ways, which is why it's gotten delayed. But everybody's had long enough to get ready. I suspect they're going to go ahead with it. We'll see. So all carriers that are required to be HIPAA compliant, which is almost everybody, are required to make the conversion. So almost everybody you're going to send bills to will have to be compliant. The exceptions are few, but workman's comp may be one, and if you do workman's comp cases, you may have to keep your old software so that you can continue to report with ICD-9 for those few cases, but probably most interventional radiology is going to completely convert over. Like I said before, and I'll say it again, if the systems fail, you will not get paid, and failures may occur at multiple levels. I think it doesn't take much to remember what happened when the insurance exchange website went live and how bad that was and how much that didn't work and how systems failed. This has that potential. Because of that, the AMA has recommended that practices establish a line of credit to cover your expenses for 1 to 4 months in case you don't get paid. And they've estimated that even small practices will have to spend at least $120,000 to convert the software and to do the training, and it may be as much as $1 million or more for large practices. Again, I can't tell you loud enough or often enough, if you don't start reporting by with ICD-10 after midnight 9:30, your payments won't go through, you will not get paid. So where are potential areas that you could focus on to try to prevent failure? One is practice failure. If you don't establish the systems or you don't have software, that's going to be an automatic failure. You can avoid system failure by making sure that the systems and software work. You can pre-test them. If they fail to communicate at any level with your own EHR, with the hospital or facility where you're sending records and patients, with carriers, other providers of any sort, you will fail. If your physicians or providers aren't trained or don't comply with the documentation that's required to report the right code, you will fail. Coders can cause a glitch in the system if they're not trained and ready to implement the new system. Failure can occur at the carrier level. If you look at things now, all the coverage policies include covered diagnoses, which are ICD-9 codes, and if those aren't properly converted for every single one of your carriers, Medicare and private payers alike, and the coverage policies still have ICD-9 or don't have the appropriate ICD-10, it'll be a rejection. You won't get paid. So the system can fail either locally or at a global level, but it doesn't matter. If it fails, the outcome will be a probably long delay in payment. If you can't get bills in, there will be an adjudication process, but it will likely be long, and you won't be alone, and you'll be in line with multiple other people trying to get paid. And it may really be that you have a long period of not getting paid. So it is well worth putting in effort and time and training and getting your practice ready for this. There are some areas where it may give you some improvement. There are some areas where it may slow things down. So in your operational coding and billing workflow, if your IT system's not ready, it will cost you to get them ready. Productivity may suffer on your coding side because it will take a while for everybody to learn, and now they just rattle off the ICD-9 code and it just goes on there, or you probably can too if you pay attention to this. Your coders are going to have to learn a whole new system, and there will be more codes for them to learn. They'll have to type in more characters to get those codes in, so it will take them longer, and you'll have to pay for that time. Reimbursement, the hope is that eventually it will, you will be paid with less administrative burden than in the past. Documentation, we'll talk about that a little more. Because these codes are more specific, the reports and documentation need to be specific in the areas where you need that specificity to select the appropriate ICD-10 code. So the software systems have to be able to prepare, send, and receive and process transactions. At any level in that process, you have to make sure that your systems can handle the ICD-10 and communicate with each other. You'd hope that they will pick up data automatically from the EHR and then communicate that data to and from the practice, other providers, carriers, hospitals, facilities. It's not enough to have your own internal system in order. You can be working just great, but if the hospital can't accept your information coming in, or the Blue Cross carrier in your area can't accept it, you're still not going to get your billing done appropriately. So the best thing to do is to test ahead of time, especially check with your high volume payers. Are they expecting delays to occur? Are they going to allow testing? When will they allow testing of the systems? Check with the hospitals and facilities you work with and refer to, see if they're going to allow testing and when that can happen. And check with anybody else that you would use on an ongoing basis, labs, imaging, other physician offices. Medicare has set some specific dates for pre-testing. You need to look and see when that is and make sure you're on board with that so that you participate in the pre-testing with your Medicare carrier, and then look at other hospitals and practices, anybody who you need to send information back and forth to. Our recommendation is that each practice have at least one physician champion within the practice. You can't assume that office administration or the hospital is taking care of this. All clinical input is definitely needed. And again, you are the one as a physician who's responsible for compliance with the conversion deadline. For coders, there will be some codes that will crosswalk from ICD-9 to ICD-10, but it is certainly not all of them. You can help your coders by having a list of ICD-10s that correspond with procedures that you do more commonly. FSIR will be working on some lists to share with you to use as a resource as well. Expect that, like ICD-9, you're only going to use a small percentage of the total codes, but it will help your coders if you can zero in and say 95% of my cases are going to be with this list of codes. Education will be important on teaching your providers how to document. Does ICD-10 require a change in documentation? Probably yes. You need to be sure you have communication between the providers and staff. We'll talk about that, and get physician and staff engaged in a query process to improve your compliance and to maximize your payments. Do I need to change how I document? Well, if you ask the people in charge of ICD-10, they say no change in documentation is necessary if you're already documenting well. But I have to tell you that even if you are an excellent documenter, you still need to be careful because you will need things that you may not be routinely documenting. And you have to know which codes so that you know how to document. Here's just one example. So in the past, if you were treating a patient with atherosclerosis and an ulceration in a lower extremity, there was one ICD-9 code you would report, 440.23. In ICD-10, there are 96 potential ICD-10 codes for that one diagnosis, and it's because it's really granular. You have to know whether it's right leg, left leg. You have to know if it's native artery problem, unspecified type of bypass graft, autologous vein bypass graft, non-autologous biological bypass graft, non-biological bypass graft, other type bypass graft. And once you get that, you have to know, is the ulcer in the thigh, the calf, the ankle, the heel, the midfoot, other part of foot, or other part of lower leg, other part of leg, unspecified site. And once you get to that and choose which code, then you can also add an additional code to identify the severity of the ulcer. And, you know, I document pretty well, I think, but I would not probably get to that degree of specificity in my H&P or my report unless I knew that I needed that to for my billing department to send this out. So that's why you really do have to know your major ICD-9 or ICD-10 codes and change documentation as necessary. So a few other things just to go over. What do I need to change on how I document? You will need primary and secondary diagnoses. You'll need to document signs and symptoms. You need to connect what you've done to the impression. You'll need to document concurrent conditions, specify anatomic sites. You need to specify whether it's chronic or acute, what the severity is. You need to say whether it's right or left. You need to know on the episode of care, is it an initial, subsequent, or a follow-up visit? Is it a sequela of another problem? And you need to document conditions also managed during that same encounter. So that's a lot of things that need to be documented to get to one ICD-10 code. And if you leave a piece of it out, the coder may not be able to maximize how you bill. Coders will need physician or clinical input for ICD-10 changes. And just like your CPT coding, if you leave something out in your report and you've got a biller who's trying to be compliant, you say you used ultrasound guidance to stick the vein for a central venous line, say, but you don't say, I saved an image to the patient's permanent record. Your biller or your coder may say, not documented, so they don't bill for the ultrasound guidance. Same thing, if you're not doing that here and you're not communicating with your coding staff, they will likely go to the next lower option, and you will lose money in the long run by doing that. So it's important first for you to know what you need to document and to do that, but then it's important for you to have a feedback loop with the billers and coders so that they, if they're seeing something and they say, well, it sounds like they used ultrasound, but they didn't document this, why don't I go talk to them and see if they did and see if they wouldn't put that in their report, and then I can bill it and they can earn some more money. If you can have that openness and not take it as a personal affront, we all need reminders, and especially when we're learning something new like this. We've done things so long that it's automatic and routine, but you're going to have to change. So get some help. Ask these people for support. They can come, you can educate them, they can educate you, you all do better. One thing I also want to point out is that E&M coding specifically is going to be under intense scrutiny. So you need to be very careful and make sure you have complete information for billing on those. But also remember that patients now pretty much have open access to their records, and if they open it up and see that you've put in a bunch of filler in there that isn't right, or they don't know where that came from, they'll probably come back and ask you about it or not come back and see you at all. So don't put in stuff that's not right. Make sure that you've got detail when you need it and make sure it's accurate. So the query process we talked about. I think probably the best thing for you to do is to actually get your hands on an ICD-10 book and look at it, read through the basic instructions in the front, look through the codes, look through the chapters, and try to find, if you do a lot of biliary work, look in the biliary section. If you do a lot of vascular work, look in the vascular section. Oncology has really changed and has expanded. And just make yourself as familiar with it. Go through, circle, this is going to work, this is, I see these, and make a list, a cheat sheet for yourself. I think we kind of went through that. The 3 to 7 characters in the ICD-10 codes. The first character is alphabetical, the second is numeric, and characters 3 to 7 can be either alphabetic or numeric. The 7th character identifies whether it's initial or subsequent encounter. As you start using these and realize you need more documentation, you also can work with your internal systems, your EHR. There's no reason that you have to put in there in the record over and over and over again that it's the right foot, for instance. That may be able to be entered on registration and then follow that chart through the patient's visit so that it can be captured in other times and it doesn't have to be repeated every time. These are the chapters, the 21 divisions of ICD-10. Some of them you won't use very much, maybe eye, ear, mastoid, maybe not so much, OB, maybe, perinatal, maybe. Just depends on what your practice is, so you'll have to look and see. The OIG has mandated that we have 95% compliance throughout the country on this. CMS will be able to see all of the diagnosis codes that you bill. It won't be just the first 1 or 2. They'll be able to see all of them. And again, E&M coding is under scrutiny, so just be sure that you've got plenty of documentation. I suspect your coders are going to be, as usual, very eagle-eyed on that, and if they don't see something, they just, if you're not talking to them, or they're not talking to you, they just won't bill it, and you will miss out on revenue that you should be getting. So what should I do? What should you do right now? First of all, educate yourself and your staff. Get started now. Don't get started in October. Check your records. Try to self-audit. Do some practice runs. Pull some records and try to code them. See how your coder does. See if you agree. Check your documentation. Make sure that it is to the level that supports the appropriate ICD-10. And then try to test some cases. See if your EHR is working. One of the things you may want to look at is sometimes EHRs will auto-default, and if you don't know that's going to happen, you may be thinking it's going to pick up something and it won't. So make sure you check how the EHR is working ahead of time. There are resources available. Debbie's worked on a lot of resources for us on the website, but there's you can also look at World Health Organization. CMS has a ton of stuff. AMA has a ton of stuff. And like I said, we're hoping that we can come out with some cheat sheets for you that would have the most common or most likely ICD-10 code you would use for certain aspects of your practice, and see if we can't give you a hand there. I think it's Stephanie's up now. Thank you.